students. Good afternoon. I'm just going to rehearse over what I discussed earlier today in the CiMO book with my students that I had earlier today. They're doing their computerized work in their books, along with the software in their books. So I'm just going to go over with you, YouTube channel, and do a little lecture on the importance of scheduling and how that all displays and work. Okay, so I can have that recorded for the sake of YouTube education. Okay, well, first of all, we're going to talk today from the CiMO book, Computers in the Medical Office. This is the 9th edition that we're going to talk about right here. And we're discussing things from chapter 3, okay, from chapter 2. Right. Chapter 2, chapter 3. So sorry, chapter 3. Yeah, here it is. Okay, so scheduling. So why is it important to schedule? Why is it important for front desk to schedule patients? Number one, it helps us do our checks and balances for medical billing and coding. So we need to know how many patients are coming in that day of to see the doctor, be it 1 or 2 days in advance before that actual patient comes in. We need to know how many HMOs we have on that list, how many PPOs, how many point of service that we have on that list. And then when we finish at the end of the day of seeing all those patients, then it has to be congruent with what the medical biller has sent out with the expectancy of knowing, okay, we have this many patients, we've had 45 out of 50 to come in. And so our expectancy of income, that includes fee for service, insurance, workers' comp, Medicare, the estimated revenue of service for that day should be $10,000 or maybe $11,000, maybe $12,000 or $15,000. It just depends. Okay, and so we need to know what to expect when we get ready to bill out, and what's our projected amount. You have an idea, a projected amount, and then let's see what we can do to apply that after posting payments and collections. What else did it fall short? Maybe there were some denials, maybe there was some pending of claims, things of that nature. So all that matters when scheduling a patient. It also matters when you schedule a patient that if you have to be mindful and call your patients in advance to remind them, hey, you have an appointment. Today's Tuesday. You have an appointment to see Dr. Jones on Thursday, or you have an appointment to see Dr. Jones on Friday. And that gives that patient an opportunity to remember, maybe look back on their personal calendar, to remember that they did have an appointment. Maybe they need to arrange a lunch time to see the doctor, or get off early, or come in late, because things happen. Patients. Sometimes you'll find patients who forget that they do have an appointment, and if you let them know 2 and 3 days in advance, that will help make the slot of patient care that day a lot smoother. Okay, and nothing missed. Now, let's suppose if you call that patient today and say, "Hi, Mr. Smith, you have an appointment with Dr. Jones on Friday." They have Wednesday and Thursday to think about that appointment and to go back and say, okay, yeah, I do remember I was coming in late, or I'm leaving early, or I'm taking an extended long lunch to see the doctor that day. Okay. Or if something comes up that morning, then they have an opportunity to call 24 hours in advance. So that's 24 hours from the time of their appointment. Okay. So let's just say, for example, their appointment was Friday morning at 8 o'clock. Okay. That means they need to call at least somewhere between 8 and 12 that afternoon, Thursday, or at least 12 and 5 o'clock that Wednesday, to let the physician's office know, hey, I'm not going to be able to come in. Could you reschedule me? Now, if you happen to call late, maybe like 4:30 or something like that, chances are you as a patient may get charged for a no-show or a reschedule type charge, simply because you didn't call timely enough. I understand things in life happens. I get that. But sometimes if you didn't call 12 noon or somewhere before 12, where an emergency patient or another patient that could have had your time slot, then that could have been accounted for with a patient that needed your time slot that could have been replaced. Okay, so time is money. Time of essence of patient care is money. Okay, and we don't like to waste money. We're not saying that money is everything, but when we're dealing with running a business and running a physician's office, being a practice manager is operating a business. Time is everything. Okay, it's not that we don't want to spend time with you or we're just looking at you as money. We want to make sure that every patient that we see receive the exact amount of care um, from that physician, just as anybody else would want that same amount of care and time. Okay, so now that's where that falls in line of being important. I also want to say that patients, please be mindful of the fact that uh, we have to know how to better serve you by letting you know that we have to charge for those things and to take our time very seriously. We take your time very seriously, at least we try to. And even if the doctor's running a little late, we try to make sure that every patient gets quality care. So you have to be mindful of the same situation that may be for you. Okay, so scheduling a time is very, very important. Okay, now let's look at this. And we also keep records, past records of that. So, as appointment setters, front desk folks, medical coders, and billers, we have to keep trends to know, okay, this patient, um, or we've seen these kind of patients this week. That week it went pretty good. This week it went pretty good last week. So you kind of want to see where your trend is and where can you do better, or where can you make a change to adjust something that needs to be changed. And that's another reason why we keep track records of our appointments. You can keep all of this data up until about a year. After about a year, you can have that data taken out, distracted from the system. So we'll talk about restoration, doing backup work or backup data for patient claims, and we'll also talk about how to extract and make room in your data storage so that you don't get your desktop or your hard drive so overwhelmed with information that it'll constantly have room, mega room or mega storage of room available for other details that needs to be stored in. Okay. All right. And also, let me also add this. When you're doing backup files for medical billing, for scheduling, have a contingency plan in place. Now, we're down here in the South. We're in Houston, Texas. So we're right in the Gulf Coast, southern part of the United States. So we tend to get hurricanes. Okay, other regions of the United States, they tend to get what do you call it? Tornadoes. Okay, we get hurricanes. So sometimes there may be flooding, issues of water. Have your backup plan. If you know that that the weather is going to be horrible, you know where your area of practice tends to flood. Try to back up everything on a USB stick. Put it inside of a Ziploc bag. I would double bag it inside of a Ziploc bag, meaning I would put it in one Ziploc bag and then have it stored in another Ziploc bag and make sure it's sealed tight. So that way you don't lose information in case you have to get another computer system. You can always upload everything on your new computer system. And I guess while I'm on this tangent, let me also say if you have desktop or laptop computers, if it raises up to be 2 or 3 feet of water in your office, and you know you're going to close your office for 2 or 3 days, or at least for a week or so, for safe reasons, contingency reasons, because of the weather, try to store your hard drives and your computers high and dry on a shelf somewhere, okay? So that way you can at least save money on your electrical devices, okay? Um, if you have a storage place, try to put it inside of a secondary, a second floor, third floor type storage place where it doesn't get harmed or affected by water. Okay, now the wind damage and everything, I cannot help you with that. That's a God call. I have no control over God's weather. However, if I can advise you as best as I can as far as water, try to store your things high and dry. Your electrical outlets, try to store them away high and dry. It's cheaper to replace electrical extension cords, outlets, than it is to replace a whole computer or certain devices. Okay. And then if there is a loss, God bless your soul. You can write that off as a loss on your taxes, your business taxes, and try to get some help from FEMA and get all those things replaced. So I just had to kind of go on a tangent there for the sake of the what do we call that? The hurricane season. Hurricane season for us in Houston is from June 1st to November 1st. Okay, so we're August, so we're not quite out the woods yet. So I'm still praying after August we don't get any hurricanes. That's my prayer. Okay, so moving right along forward, let's talk about patience, okay, and what it is to have that recorded in the system. I need to find my marker. All right. So when you're scheduling for an appointment, okay, please be mindful that if a patient has not seen a physician in the office, let's just suppose the patient is brand new. He's coming in for a consult. He's coming in as a new patient. Then you want to list them as that, and you want to give them a good time range of 30 to 45 minutes for that, because the doctor needs to have a consult time to talk to the patient, listen to the patient, find out exactly what's going on, read their data if there be any data from a referring physician or from emergency room of such, and then know how to think and treat the patient at the same time. Okay, so anytime you get new patients, you always want to give them a 30 to 45-minute slot. Okay, sometimes an hour is at best because the patient may have a lot of questions. The physician may have a lot of questions. Okay, all right. So now this is considered when they are never seen by the physician or last seen in 3 years. What does Ms. Harper mean by that? A new patient, even though the patient has seen Dr. Smith August the 14th, 2013, okay, 2014, okay, and it is now 2018. That has been well over 3 years. He is now considered to be a new patient. What does that mean? Anything could happen between August 2014 and August 2018. Okay, we don't know what all the patient has been through, body-wise, ailment-wise, environment-wise, socially, mentally. We don't know what all the patient has gone through. So that is why they are reconsidered as a new patient. And then as a medical coder and biller, you must, under the E&M codes, the evaluation management codes, give them codes that are complementary of new patient codes and the time slot that matches that. Okay? All right. So, and explain to the patient, because the patient may say, well, I've always come to Dr. Smith. Well, yes, you have always come to Dr. Smith. You've seen Dr. Smith in 2014, sir, and you were regular for the last 4 years at that time. Now things are a little bit different. We don't know what you've been through and what you've been doing. So we have to reestablish ourselves with you, and you have to start over with us as a new patient. So this is why you're paying $150 for your office visit. We got to start you over, okay? Doesn't mean we want you to come in for nothing. and just for the sake of saying I'm here so I can stay established. No, we have to do this for documentation reasons and for care reasons. Everything has to line up with all the labs and the x-rays and any type of progress note care that we do, because if something happens and it's subpoenaed by court, it is a legal and binding document. Even the scheduling data is a legal and binding document. So we have to do things the right way. I hope you folks out there in YouTube land working in these doctor's offices are doing things the right way. Okay, now let's talk about established patients. Established patients is one who has been usual or frequently seen within a 3-year span. Okay, so those are established patients. Now, those are the ones that get those particular codes that may say $75, $100, and so on. So you're going to go under evaluation and management, and you're going to choose the established patient codes for those particular type of patients. Even if they haven't come in and seen a doctor for a year, you still going to charge them as an established patient. Now, if it's just straight out 3 years, they have not seen a doctor, straight out 3 years, consistently 3 years, then yes, they are considered a new patient. But if they come off and on every 6 months or maybe once a year, then they're established patients, okay? And then if it's something else different, maybe a physical or something else, then yeah, you would have to use a different E&M code for that. Okay, I hope you understand that. If you don't, please address it in the comments section and we'll talk about it. Okay? All right. Now, let's look at this. Most of the students and most of your vocational programs are going to learn MediSoft, okay? MediSoft is a common software program for patient appointments. It is very rare in my years of experience, and I can't put a exact on it, but in my years of experience that I've ever seen MediSoft used in hospitals. You have Epic, you have NextGen, you have there's another one that's popular at what hospital I worked at that are pretty popular in hospital base because their databases and the software system is written in such a way where it accommodates such an infrastructure for hospital care. Okay, MediSoft is large enough to accommodate a capacity of a practice management, maybe of 3 physicians, 2 physicians, 1 physician, 4 physicians, maybe even 5. They can do that. But I have yet, in my personal experience, seen MediSoft used in an acute care setting. Okay, so that's what I mentioned to my students. MediSoft is a pretty popular software for physician offices. Now, you do have some physician offices, they will use eClinical, they will use other billing scheduling type software. But if you happen to get a job working in a doctor's office and you're using MediSoft, woohoo, good for you. That means you have hands up. But you still may have to train that person on how to use your personalized MediSoft, because there may be certain features that you have had added onto the MediSoft software from the MediSoft company, from McKesson, that it may not be necessarily inside the classroom or at other physician offices. I hope you get that. That particular person may be familiar with the formalities of how to use patient demographic information, the patient list, the guarantee list, and all of that. But you may have extra added features that are not in everybody's MediSoft software in other practices of maybe where they work. So please be mindful, even though that person may have experience in MediSoft, that's great. That cuts down 50% of your training and knowledge of what to do. You just need to teach them the added stuff, okay? And try to be patient and be nice. Don't be mean. You want someone to do an efficient job, be efficient in being a good trainer, okay? Don't suck at your job. I just hate sucky people that don't train well, and then you expect that person to do a good job, and you give them half-cocked information. I'm sorry, I take it real personal, really personal, and it ticks me off. Okay, now, other information. We talked about signature on file. Now, earlier today, when you're putting in other information, that other information could be insurance information, guarantor file information, okay? And you have to update this every year, okay? You have to update this every year. When you update this every year, then you have to do this by paper. So I'm alluding to this, but and you have to change the date. So say, for example, once they fill out all the necessary paperwork, the financial responsibility, they say, I'm okay with receiving a bill. I understand that the insurance company may need copies of my medical records to pay the claim. I understand that, what else goes along with that territory? That the insurance company is going to release payment to the physician's office. Okay, so here I am on number 12 on the CMS 1500 form. Here's my signature for that. Okay, and for the signature on number 13, here's my signature for that and the date. And okay, we're good to go until a year from now, from the date that that person signed. You have to renew and update those paperwork from the year that that person has signed. Okay. All right. So again, demographics, renewing paper contracts and everything, in case that person is sued or that medical record is subpoenaed for court, you have it all intact and up to date. Okay. Because remember, in medical records, everything is legal and binding. Okay. Now, number 12, number 13, and number 27 on a CMS 1500 form is very, very important. That ensures, unlike what my student says, it is important because it secures the provider's payment. That means the provider will get their check as promised. Okay, we're not going to have any slip-ups or accidents of the check going to the patient, and then the patient say, "Oh my goodness, I received a blessing. Oh my God, this is a check from the insurance company. Sweetie, that was sent in error. You need to call the insurance company. You need to call the doctor's office and make sure that it doesn't belong to them. Because if it does belong to them, you need to sign the check over for them to have it, not you. Okay? If not, you will get a bill. Okay? All right. Now, electronic medical records is very important in medical billing because you have what we have here, electronic medical records, we have medicine. So for medicine, we compare and combine medicine and Medisoft. We kind of interface them together where we're able to extract medical record and send to the insurance company for appeal reasons, different things of that nature. Okay. And so when that happens, you're able to get things done a lot faster. Okay. And then there is a statute of limitations of time when you need to appeal something or correspond to something. And correspondence is what I mean by when they say, I need copies of the medical records for this data service to justify this or to further explain that, or I needed copies of the, details to further explain the coordination of benefits. Okay. You have to sign that box 12, 13, 27 for that to be released to the insurance company. So all that plays a role. And then it's when electronic health records and electronic data interchange, when the Medisoft software is enmeshed together, interface together, you're able to extract information and pull it over and then send it forth electronically to the insurance company, or print it and you can send it hard copy, paper-wise, to the insurance company or Medicare. Now, if you're doing it on an appeal basis, if you're doing that on a correspondent basis, then you're not going to be penalized. It's when you're billing initially by paper, and I think the meaningful use should be ending pretty soon. I think 2021, if I'm not mistaken. Anything after 2021 and you still sitting in paper claims, you will get penalized. Okay, so I'm just telling all you doctor gurus out there, be mindful of that. Okay, all right. So we talked about the billing part, abstracting medical record information so that you can attach it to the CMS 1500 form and send it again electronically or send it hard copy by mailing it. Okay, very good. Now, we also talk about updating information. You remember those wellness papers? Sometimes you see a doctor and it may say on a scale of 1 to 5, do you feel depressed today? On a scale of 1 to 5, do you have a hard time putting on clothes? On a scale of 1 to 5, do you feel hyper? On a scale of 1 to 5, how often do you eat? You know, those are called wellness checks. Those are called wellness forms. And every now and then we will have the patient to fill out or do a survey of a wellness form, because you can come in and see us face to face about one issue that's going on with you, but there are telltale signs sometimes that we don't necessarily see on a person's face or countenance, if you will, or how their talk or their speech is, or how they gesturizing themselves. So sometimes if they acknowledge it by paper, it helps us to recognize, okay, let's also address this issue. Are you feeling depressed? Well, what's going on? Well, how's your social life? What's your social status? Do you drink? How often do you drink? What do you drink? Do you drink a lot of coffee? Do you drink a lot of gin and juice? I mean, those kind of things, okay? All right. So it helps us to understand the patient on a socioeconomic level. Sometimes socioeconomically, a patient can be affected, okay? All right. Paperwork updated, okay? So you have wellness paper check, you have the guarantor, okay? We need to know if the guarantor information is going to change, okay? Now, meaning that the guarantor information, how can I say? Let's suppose a divorce has happened and Sally Sue is married to James Joe. Okay, James Joe and Sally Sue are no longer together, and all the bills used to go to James Joe. So now Sally Sue is on her own, so the financial responsibility has changed to where Sally Sue gets her own bills, and it no longer goes to James Joe. Okay. All right, so we need you to, as front desk clerks, as appointment setters, please make sure, watch out for the dates of the last guarantor application, demographic paperwork that they filled out. If it's been a year or about to be a year, and sometimes if it's been 6 months, you want to have that updated, because then life events do happen. Change does occur. We need to know that. We don't know. We don't read minds. We don't read minds. So we have to know by asking and hearing and writing. Okay? All right? We don't assume. When you assume, you make a what? Out of you and me. You know what I mean? Okay. Now, permission. You have to update the permission form. The permission to release information in contact emergency. Again, a date from a year from that date that the person last completed out those demographic forms. If mama used to be your contact person, now you changed it to where it's your spouse, then you need to update that. Okay? And we do this for HIPAA reasons. Okay? Let's suppose that for permission to release information on your telephone voicemail. Maybe through text message. We'll let you know that you have an appointment through text message. Email, your job email or your personal business email. We need permission, and we need you to initialize, to put an initial to say that you have permission to send me a voicemail, text, email me. You have all those permissions granted, and my initials are placed there, so it's legal and binding now. Once you give us permission, you're saying okay. Okay. Also, mailing address. Okay, we have to know, do you accept us to mail results to you? Yes or no? You need to check that. You need to put an initial by that. Okay, and if so, where should you? Where would you like for us to mail? Don't put same in there. Same as what? You can have a PO box and a physical address. Same as what? Okay, we're not going to assume for you. So you need to make sure that that patient put that information. We need to know, we need for you to write that down. Do we need to mail it to Big Mama's house? Do we need to mail it to your house? Do we need to send it to the P.O. box? Okay, we don't assume same is not acceptable. We need to know exactly where would you want us to mail it, especially if you're having us to send vital information. Okay, release of information, emergency room documents. So, I'm sorry, if electronic medical record document, excuse me. So you have that release of information form. So say like, if you've seen the doctor today, or maybe you've seen a specialist the day before, and you're back to seeing your PCP today, then we need to have a blank release of information on file. Leave the date blank, so that way we can keep reusing that same release of information form without you having to fill it out over and over again. And we can fax it to those different providers, and you just give us the name and address and the fax number of that provider and the phone number of that provider. So we make sure that that provider gets that information and can give us what we need to better serve you as a patient. Okay. All right. And the next thing, the last thing, thus far we've gotten through to chapter 4. We talked about diagnosed related groupings. So a lot of times when you're building cases in Medisoft, you have a stack of cases that's diabetic, another stack of case that's hypertension. Okay. So as you're building cases, they're lumping and grouping these two different diagnoses together, and maybe other diagnoses thereof afterwards. Okay. They have to do that so that when we do send off the billing off to electronic data interchange through the clearinghouse to the insurance company, the insurance company will know that these are chronic conditions. Chronic means constant, ongoing. Acute means short. It happens once a year. It's very short. Chronic happens frequently, 2 or 3 times, 4 times a year. Okay, then that tells the insurance company, okay, this person is diabetic. This person sees the physician for this diabetic reasons. So therefore, we're going to list them under the DRG, diagnosis related groupings. That means that any time that the insurance company wants to pay out to the physician's office, to the provider's office, the hospitals, that they would pay at a more discounted rate. It leaves room for the lifetime max. As I have explained to my students, for insurances, for every person, there's a $1 million lifetime max. And I've worked in the insurance industry where we had to keep tabulations of how much that patient has utilized of their $1 million insurance medical policy. And there were some cases on the insurance perspective that I've had to deal with some patients who were like 800,000. 700,000, and it ain't even the end of the year yet. Okay. And that's where DRGs became most relevant and important, because if you discount by 5 or 10, 15, $20,000, it kind of gives more wiggle room for it to not reach $1 million before December 31st that year. Okay. If it does, chances are it does happen, especially in transplant type situations. Then the doctor's office would have to write a letter of medical necessity. They would have to do a letter of appeal to the utilization review department to try to see if they can have that extended. At the same time, the doctor's office and the insurance company has to talk to the patient and let them know, hey, you've reached a $1 million max. We're trying to see what we can do to increase it for another $1,000, $100,000, or $200,000, but that means next year your premiums may increase. Instead of you paying $300 every 2 weeks, you might have to pay $400 every 2 weeks to make up for that increment increase for you to have continuous care under coverage, or you just won't have coverage at all because that'll do it for me. This has been about 35, 36 minutes of lecture time, which is short for me. Because I usually go about an hour, hour and a half. Sometimes I'm not careful, I will go 2 hours long. But this is on for CiMO book, chapter 3, dealing with scheduling in your book. If you have any other questions, any other comments, please put that at the comment section below. Get in touch with me. You know my email address. You know my phone number. Text me. Let's chat. Let's talk about it. And I will see you next time. This has been Mrs. Tara N. Harper for your health information. Have a great day.